Hello, everyone. My name is Addala. I'm a pediatric endocrinologist at Stanford University, and I have the distinct pleasure today of talking with you not just about the state of diabetes disparities right now, but also specifically focusing on solutions for equity so we can think about what our next steps are going to be. I have no relevant disclosures or conflicts of interest, and I have research support from these following institutions. And I'm going to start really here at our roadmap for what we can do. Now, this is an image that was created that is grounded in the social ecological model, which essentially says that there are actually drivers of disparities that range from the individual to what we call the interpersonal, which is where clinicians typically sit, to institutional, which is where many of the clinics that our families are being seen in and our individuals living with diabetes are being seen in, along that's then nested further within the community and even further still within societal and policy level structures. And what I've done in this figure is really first off identify some key personnel. So who are at each of these levels who could really make sure that they're making a difference in diabetes outcomes and diabetes care and really working towards what I think we all hope for, which is equitable care that really helps everybody succeed and have diabetes care and management be congruent with what they would really like for themselves. And then as you move further across the slide, what you see are key actions. Now, each of these actions has a citation next to it because these are evidence-based citations and actions that folks can take right now, depending on where you are within this roadmap. And what I'm going to do is focus on some of these. But before we really dive in, we're going to talk about really what are the objectives. I like for you to know what is it that we're going to be discussing today so that it's really clear from the get-go. But first and foremost, I'm going to really try to establish diabetes technology utilization as a modifiable risk factor, which is why I jokingly say I'm quite obsessed with making sure everyone has diabetes technology. And it's really because it's one of the very few things that I can modify. So this is a recent publication out of the Type 1 Diabetes Exchange, but versions of this can be seen throughout the globe where there are certain characteristics that are associated with in-target versus out-of-target hemoglobin A1C. And you'll notice here I'm talking about A1C because one of the fundamental points I'm going to try to make is that not everyone has reliable, equitable, and adequately educationally supported at the institution level CGM access and utilization. And if I go down this table one list, I can tell you that I cannot change how old somebody that I'm working with is. I can't change the duration of their diabetes, nor can I change, nor should I change their race and ethnicity. I have no influence over what insurance, which is a really key indicator in America, both of socioeconomic status, but also of the type of care that you're going to get. But then you come to this CGM use, insulin pump use. Now, as a clinician, that's something that I have influence over. So to me, the reason that that really diabetes technology has become a real focus is because there are very few things that I can have any influence over. And I want to make sure that I address this modifiable risk factor as best as possible. And the second thing that I like to kind of talk early on is what is my definition of disparities? Now, I actually like to keep things as simple as possible, despite what you might decide by the end of this talk. But, I think that the best definition that I've heard of what a disparity is it requires two components coming together. It's an efficacious treatment that has inequitable access. So it's something that works well that not everybody has access to. And that's some of the data that I'm going to show is what sits in that overlapping Venn diagram to say, yes, diabetes technology, the data are at this point grade A evidence that having CGM, insulin pump, and AID systems, hybrid closed loop systems, significantly improve not just glycemic outcomes, but also well-being, the quality of life and how well someone's doing. In the case of parents, their ability to sleep. The benefits are so overarching that it's really important that we don't lose sight of this. And the inequitable access is what I'll outline here. And I'll really focus on this underutilization of technology. And the first component of how this emerges is that you have this disparity in hemoglobin A1C in the United States. Again, this is type 1 diabetes exchange data because they're reliably socioeconomic factors and race and ethnicity are collected. And what you can see is individuals who identify as non-Hispanic Black have significantly higher A1Cs than their counterparts, followed next by those individuals who identify as Hispanic, Latino, or Latinx. And then the lowest hemoglobin A1Cs with those who identify as non-Hispanic, White, and Black. And it's really important that we recognize here these race and ethnicity categories were truly sort of divined by the US Census early on in the day. So this is actually not an indicator of any biological underpinnings, but rather they seem to actually best measure what the societal and kind of social experience of what it means to be a certain person rather than anything that's biologically based. And so oftentimes we will discuss or you will hear the words race as a social construct. And that's really what we mean, that these differences is not that there is something biologically different about an individual who is Black or otherwise. It is that the way that our system has chosen to deliver the care, the way we've created our public policies and all is really the big reason as to why we get these differences in the care and in these health outcomes. And one of the ways that this shows up is in access to diabetes technology. So this is a 2021 paper, again, out of the Type 1 Diabetes Exchange. And what we show here is that individuals who identify as non-Hispanic Black have some of the lowest pump and CGM use. And those who identify as Hispanic have the next lowest. And then we go up to non-Hispanic White and sort of this category other, which again speaks to sort of the deficit of the way that we in America have chosen to do racial ethnic categorization. But also this is a global consideration because there are race and ethnicity categories that have been constructed often by governments that many researchers and clinicians follow suit. And they truly don't get at any biological underpinnings, although there's often a conflation of that. And then the second component is that we miss what it actually means to understand what the underlying drivers are, which is really, for example, in America, it's the experience of racism that really gets at these differential outcomes. And there's data to support that as well. The other component that's very big in the United States is the socioeconomic status and how that really is how policy is designed and divined and how care disparities really emerge. And so this is a paper that came out in 2021 where we collaborated with our colleagues in Germany. And what we did was we looked at about 17,000 kids in the United States and about 40,000 kids in Germany and said, okay, let's put on the y-axis percent of CGM use. And then for every child in the United States and Germany, we've identified and kind of calculated a socioeconomic value. Essentially, when you average their parental income, parental education, and insurance level in the United States, or you look at their area deprivation in Germany, what is it that their number is? And then we sort of broke them up into quintiles, grouped them into 5 groups and said, okay, they're the kids who are the highest socioeconomic and those are the lowest. And we looked at 2 time points. The light blue is the earlier time point and the dark blue is the later time point. And hopefully what you can appreciate from this graph is that from the earlier to the later time periods, there was, sure, everyone went up on their technology use, but that technology use was preferentially uptaken by those of the highest socioeconomic status. And this is a trend that's seen in almost every form of society. So we've described it here in diabetes technology, but in many places, what happens is that the most innovative, the most cutting edge, the most sort of next, future frontier interventions or comforts, sometimes it's not even medical, are taken up by those with the greatest amount of financial income, but also those of the greatest privilege. And many times it's thought that actually the lower socioeconomic individuals are they either don't have adequate education or health literacy or interest, et cetera, to take this up. And I think that in the United States, we had a very humbling lesson that we learned from our colleagues in Germany, because what this really shows is that the reason that there is a preferential uptake of the highest socioeconomic youth of CGM in this later time period is entirely systems driven. There's actually a very beautiful review that was done on how the United States and 13 other high income countries spend their GDP. their gross domestic product. And what's very clear is that the United States spends the majority of it not on social support, whereas many of these other European countries do. And so I think really thinking about where do we as a country have our priorities, ensuring that there is not this preferential uptake. And I'll bring you to this next, again, kind of coming back to why do we want folks to be on technology? It's because it's a modifiable risk factor. And what we found in this study was that whether you are a youth of the highest socioeconomic status or the lowest socioeconomic status, compared to their earlier time points, everybody's A1Cs went up. But what you can hopefully appreciate is that the lowest SES youth, the kids from the lowest socioeconomic status, had an almost 0.5% A1C increase, as opposed to just a 0.1% increase within the highest socioeconomic quintile kids. So what that's essentially saying is that the poorest kids in America were doing worse by the end of this decade relative to their well-off counterparts than they had been at the start. We really kind of worsened and widened the gap. And then we did an additional set of analyses that showed that this widening of the gap was very clearly driven by diabetes technology utilization. And what's interesting here in Germany is that everybody had an improvement, but you can still see that there is a strong socioeconomic relationship. It's not as strong as in America, but it's definitely there. And I think there's actually a very important point. If we could go back and rewrite part of that discussion of this paper, I think I would really underscore this, which is that diabetes technology access and utilization is one modifiable risk factor, but it does not negate the adverse impact of poverty and of many other system level drivers of health inequity. So it's really important that as clinicians, as researchers, we take diabetes technology utilization as a first step, but don't just stop there altogether. And a lot of people had wondered, well, why is it though that the most well-off youth in America were doing worse by the end, even though they had great access to technology? And there's this lovely modeling paper that came out of the search data in the United States. And it's really always wonderful when math can come up with the answers. And so what they did was they said, okay, let's look at all these kids in the search study, and let's look at the probability of them receiving an insulin pump. Okay, it's just modeling propensity scores that they did here. Maths that frankly is a little more complicated than I can understand, but I can understand the take-home points. And what they said was, let's look at the red is non-white kids, and let's look at the blue, and those are the white kids who identified as white. And what they found was that the likelihood of receiving an insulin pump, if you are a non-white youth, was less than 0.6 or less than 60%, whereas the likelihood of you receiving a pump if you were white or identified as white was upwards of 0.8%. And so you can see that the likelihood of getting an insulin pump, the propensity to get an insulin pump, was much higher in those individuals who identified as white than non-white. And then they took it a step further, because many times as clinicians, we're trying to make sure that there's not behavioral concerns, or that the ability to manage a pump and some of those things are looking okay. And what they said as a proxy to engagement with their diabetes, they said, let's look at the probability that SMG sort of fingerstick blood glucose tests, because that was some of the data that were there reliably. Let's see how many times they check their blood sugar. And they found that generally speaking, the probability of checking your blood sugar, the expected number of times, that distribution was equal. The ends are different, so that's why the peak is higher, but the overall distribution is about the same. And when they modeled this out and said, hey, what if we made sure that the kids colored in red got insulin pumps just like to match the probability of the kids who are in blue, they found that actually there was a population level mean reduction of A1C by 0.33. So what does that mean? That means that if as a system, we had made sure that our non-white kids and our white kids got the technology distribution equally in a similar manner, then it's not just those non-white kids who benefit, but the population as a whole improves because of this equitable approach to getting pumps. And so that's why the title of this slide is "A Rising Tide Lifts All Boats," because that's really what this is showing. And what's lovely about this is it validates a lot of what I think we intend as clinicians and we intend as researchers, to make sure that everyone has access. And now there's sort of proof that it's not just the minoritized kids that we're helping. And so now I'm going to really, now that I've underscored that there's certainly a disparity, that there's some base principles that we can build off of, let's get to what those modifiable kind of, how can we make sure that modifiable risk factor is not as much of an issue? So what can we do so that we're not just saying, oh, there's disparities, what are we going to do about it? But we actually have a chance to. And the very first thing is actually to realize that we hold many identities. I think this is often something that isn't explicitly sat and thought through, but how we measure these various types of identities really matter, and because it helps us benchmark. And so there are these multiple ways that people can have an identity, and it can, as you go and look in this image, the center is those who hold power, and the outsides is those who are more marginalized. And you can see all of the various identities that a person can hold, and how, although you might be marginalized in some areas, you might actually hold privilege and power in others, and vice versa. And that's really helpful because we can realize that there's actually, although we're marginalized in certain ways, we might hold power in others. And the other thing it does is that when we hold power, then we know explicitly where those are. So we really can be in a position to act and to really say, okay, what are the steps that we're going to take? So like I said, this whole section now moving forward is going to be around solutions we can take on. So not just understanding how our families, the individuals living with diabetes are, how their identities fall in this colorful wheel, but also how our own does, and we know where we can really act and step up. And so in this consideration of how you measure marginalization matters, this is some unpublished data, but these data come from the 4T study. I'll actually go back just a second so that I can really set it up. The 4T study is based in Stanford, and what it looks to do in sum is if it's a child with the new diagnosis of type 1 diabetes, within 1 week or so, I think our mean time to initiation is about a week. We make sure that every child newly diagnosed with type 1 diabetes is offered a continuous glucose monitoring device, that they get education to know how to use it, and that it's done in a linguistically and culturally congruent manner. So if many of our patients are Spanish speaking, monolingual Spanish speaking individuals and families, and so oftentimes we will have a Spanish speaking certified an educator who will come in and do their training for them. And we ensure that then there's a follow-up visit after that, that's virtual, that where we troubleshoot any questions that's dedicated to the CGM itself. And because we approached every single person who was newly diagnosed, we made sure that there was no clinician judgment. Oh, I think this family would be a great candidate. Oh, I think this family has a lot going on. We also made sure there wasn't any researcher input on who got approached and who didn't. And then we tried to really make sure that every single person had a cloud connected device in the version that I'm about to show you now. There's a separate set of data I'll show you, and that about why that matters. And what we said was, okay, let's look at how we did. The fact that we tried to do these equitable measurements, did we do well? And did we do well across the various identities somebody could hold, coming back to that color wheel? And so now we get to sort of, race and ethnicity in the United States. Okay, so the green line here is individuals who identified as Hispanic. That sort of periwinkle purple is those individuals who identified as Asian. And then the orange is non-Hispanic white. We do not have a significant non-Hispanic Black or Black population in our cohort. And that's why these are the three races and ethnicities that we've measured. And what you can see is that compared to our Hispanic individuals, our non-Hispanic white individuals have a 1.4% A1C improvement by study end. And our individuals who identify as Asian are kind of somewhere in the middle. And so there is a significant difference. And when we go to look at specifically hemoglobin A1C by insurance status, so public insurance is typically associated with lower socioeconomic status, and private insurance is typically higher socioeconomic status. You can see that there's again a 7.5 versus 6.9% A1C difference between being minoritized versus not. But that difference has gone down, is what you can hopefully appreciate. Before, it was, the delta was between if you look here, is 7.9 and 6.5 at its most, and here it's 7.5 and 6.9. So you can see that delta is closing in a little bit more. And then it closes in even further if we actually measure by area deprivation, which is the regional in that zip code, in the neighborhood they live in, the difference is actually as little as 0.1%. So this was a really helpful visual for us, and we are in the middle of doing a lot more analysis. So that's why this is very preliminary, unpublished data that we really do need to investigate further to understand why is it that with these different areas of measurements of marginalization, we get such vastly different differences in hemoglobin A1C and differences in disparities. And you can hopefully appreciate from this example, it's the same cohort, same time period, same A1C, same kids, but what you choose to measure by, right, matters. And we can inadvertently sort of pat ourselves on the back and say, hey, we've done a great job, if we aren't using the right variable to think about where the best, what the best measurement might be. And so again, we're really working to try to understand whether a composite score, what would be the best way moving forward. And that's what our statisticians are working on. But I just thought this was a really lovely example to underscore that marginalization and identity can present differently even within the same group of individuals in terms of how much of a disparity you see. The other way we've seen identity and who a person is matter is what we call intersectional identities. So this is a pilot study that we looked at. It's a small n of a little over 30 parents of children, young children who have type 1 diabetes, and they all have public insurance. So they all have a socioeconomic marginalization or minoritization. And on top of that, the majority of them, a vast majority, identified as Hispanic, and then a smaller portion identified as non-Hispanic. And then what was very interesting is that within our Hispanic cohort, there was a group that preferred Spanish and a group that preferred English. And what we were initially surprised, but then it made total sense to us, is that some of these values are not significant, but you can hopefully appreciate that we think this has a little bit more to do with the power than it does the effect size. So you can hopefully appreciate there's a scale called the everyday discrimination scale, and it really does just measure that in your day-to-day life. How often did you have how often did you experience discrimination? And interestingly, our Hispanic individuals who preferred parents who preferred English endorse almost double the rates of discrimination as our Hispanic families who spoke Spanish. And interestingly, they had lower diabetes technology acceptance, statistically so, than their counterparts. And our non-Hispanic white individuals kind of sat somewhere in the middle. And what we did was when we then put a sort of simple univariate model together, comparing our Hispanic Spanish-speaking parents to their counterparts, the overall trend was actually quite significant, that technology acceptance was lowest in those individuals who identified as Hispanic and preferred English. And we thought this was really curious because the thought has always been that, oh, well, the experience of discrimination is likely to occur for those individuals who are Hispanic, and that's the non-minority group here in the Bay Area of California where the study was done. And we were surprised initially to find this language difference. And so this is an example of intersectional identities, and we hypothesize a few reasons why this is occurring. And we have a larger study underway to try to understand this. But we really think this is happening because many times if you're Spanish speaking, it's usually a first generation kind of coming in. And there is a lot of fundamental needs that need to be met. And also oftentimes are using a translator. And so some of those nuances of what a person what microaggressions might have been carried out may have just been missed on that group. The other component is we think that Spanish versus English gets the degree of acculturation. And there are data in the anthropology and sociology world that really says the more someone who's historically been othered is sort of integrated into the new community, the more they recognize and reflect and say, oh, that's discrimination. And so we think that's some of what's being picked up. But I will tell you, when we first ran these analyses and we looked by ethnicity or by language, we actually miss this association altogether. So again, really underscoring that not only how we measure marginalization, how we collect those identities, but also understanding that they play this intersectional role. No person is just one thing. They're not one-dimensional. And these other aspects of their identity really influence how they end up approaching their health decisions, even though it seems completely unrelated to us. And part of the reason why we think that this really does play a role is that implicit bias. And this study was done amongst clinicians in America, really seems to play a role in clinician implicit bias on whether a clinician recommends technology or not. So this was a study of 109 clinicians in collaboration with the Type 1 Diabetes Exchange Quality Improvement Initiative. And what we were able to show, and this first finding is a re-demonstration of a pilot finding that we had done earlier, where this novel tool was tested. But it essentially showed that clinicians who spent longer time in practice were more likely to have insurance or payer-mediated bias. And that's often because they've gotten a lot more rejections, a lot more no's, a lot more what we call prior authorizations, and some of the challenges that are inherent to the US system. But what was newly demonstrated in this paper and was very interesting is people who said that they were really confident recognizing their own racial bias were actually most at risk for having racial bias, and in an implicit fashion, again, not in an explicit. And so I think it's really important that we understand that inadvertently, researchers and clinicians end up playing a role. And so that's why automating and standardizing our procedures in the clinical world or in the research world can really, really be beneficial. And I'm going to take you back again to another one of those 4T example. If you remember, that study is the one where we start individuals who were newly diagnosed with type 1 diabetes on CGM our goal was within 1 month, but we got to them usually a week or so. And this was actually the first phase of that study. This was the pilot study. And in the pilot study, what we wanted to look at was what proportion of our participants were under an A1C of 7%. Now, in some countries, that's not that big of a deal, but in America, it certainly is, because oftentimes our average is above that. But it gets at this concept that equitable technology access is a first, but not only step. And we looked at our cohort by insurance status, again, a proxy to socioeconomic status, and then race and ethnicity as a proxy to racism. And I'm going to orient you to this graph. And so on the y-axis here is the percentage, and then on the x-axis is months since diagnosis, 3 months since diagnosis, and 12 months since diagnosis. The gray bars are a historical cohort that didn't have systematic, where everybody was approached, but rather clinicians decided whether somebody was ready for it or not, or maybe they negotiated with families. Whereas the blue bars are the 4T pilot study, where every single person at diagnosis within that first week to month at the most was approached. And what you can hopefully appreciate is, although the cohort starts more or less the same-ish at the start of the study, right? So by 3 months, you've kind of hit, partial clinical remission or the honeymoon state. And so you kind of get everyone to approximately the same point on the front end. But by 12 months, you can see a very clear delineation where the 4T cohort, irrespective of whether they have private or public insurance, do better than the entire historical cohort. What you can still appreciate, though, is there is this persistence of a gap, right? So there was about an 11% different, 11% fewer people who had an A1C less than 7 in the historical, and then it's 10% in the 4T cohort. So you can see that gap persists, but our kids do better than they had historically. And the historical cohort was literally the 2 to 3 years preceding the start of this study. And when we looked by race and ethnicity, we saw something very similar, right? We saw that at 3 months, they were approximately the same. And then you actually get a more dramatic step off when you come to the 12-month mark. You see that first off, yes, our Hispanic kids are doing much better than the entire historical cohort. And you can appreciate, though, still, however, that gap persists. And again, this is harking back to that Germany data, where even though they had equitable distribution, there is a disparity in the A1C. And those are really structural social determinants of health And many of these steps that we've been discussing is to try to counter that. But again, one of the few modifiable risk factors is technology access. So if we can make sure everyone has access to it, and not just access, but the education that goes with this, that's all really important. The other thing that we do is this is that same study, and I'm gonna draw your attention to this portion of the table one, which is the CGM wear time. Now, it's been consistently shown that you should have about at least 70% wear time of CGM for it to be efficacious, ideally more, but at least that much is what the initial studies had shown. And we were really struck by the fact that although the overall sensor wear time was close to 92%, um, in our minoritized youth, those who identified as Hispanic and those who had public insurance, their rates were all the way down at 52% if you identified as Hispanic, or 62% if you had public insurance. And we were frankly very surprised by it because it seemed like most of our families really enjoyed wearing CGM, and we didn't recognize that occurring clinically. And I bring this up because a lot of people I've been hearing in conferences as I talk to people that there's this kind of perceived difference in wear time. And it took us a long time to dig into the data to really understand why. But if you remember, um, I had mentioned that we really worked towards making sure that everyone had an iPod or an iPhone or some kind of cloud-based connected device in the study, in the later study that I was talking about. Now, in this version, the pilot study, we didn't have everyone getting an iPod or a cloud connected device. So then we wondered, is there actually a confounder in the way? And sure enough, what we found was that if you group these people by group these folks, whether they were using a receiver or they were using an iPad or an iPhone, and then you looked across the across the racial and then the sort of insurance changes, what you can appreciate is that actually the people who had the lowest wear times, they were actually using a receiver. And that's why we were recording such low wear time. All we were getting was data when they would plug into the clinic and plug out. And so it appeared like they were wearing their sensors at a much less lower rate than those people who had iPhones or iPods or some kind of a cloud connected device. And I underscore this problem because oftentimes, we very easily could have said, oh yeah, there's lots of challenges, there's lots of interruptions. But by making a commitment to dig deeper into the data, we really realize actually the families are wearing it. It's just how we're collecting those data. So I share this example both for researchers and clinicians to make sure that before we come to a conclusion that we're really kind of thinking twice about how that's going. And I want to underscore, listen, our efforts work. There's been a concerted effort in the United States to try to get kids on and adults on CGM. And this is type 1 diabetes exchange data. And what we're able to show is that, yeah, it really does get better. Almost a 20% improvement. But I also want to underscore that there's been no efforts done in pump use, and AID use is clearly an emerging disparity. So it's important we don't just focus our efforts on CGM, but that we also start transitioning it into AID use. So I'll start by closing by saying, there are many roles that we all hold, and I've only covered a few of the strategies. Really, but depending on where you are in this and what additional roles you have and how you interact with individuals living with diabetes, there's lots of opportunities to make small changes within our day-to-day work practices so that we can have some improvements and more equitable overall goals. And with that, I'm gonna close with a nice image, and it gives people an opportunity to think about where they are, where we are now and where we'd like to go. And so this is a model of what it looks like to have inequity versus equity. And at the bottom here, you have two children who are identical. That's actually a really important part of this figure. There's no fundamental difference between them. It's just one happens to be standing on one side of the tree where there is a lot more fruit, and the other doesn't, and the tree is leaning. So if you think of this tree as our kind of healthcare delivery system, you can see that just by chance of where this child is standing, there is a more likelihood that an apple is going to fall. And so that's inequity or inequality. And then equality is the distribution of tools and resources equally. So here you can see why just being equal is not sufficient. The child in the blue overalls, using the same tools through no fault of their own, is not able to reach that tree simply because the tree is bent in the other direction. And so equity, which is a lot of what I've talked about today, is making sure that we're developing tailored tools to address the specific issues of the system. So not the child. That's not what we're addressing here. We're really addressing that the tree is bent in the opposite direction. Presumably the sun is over here and it gets better photosynthesis opportunities and tree, fruit generation. But you'll look, even though this child can reach the tree here, there's just not as many fruit. And so it is not until we do underlying structural system changes to sort of straighten that tree back up that you get equal distribution of the fruit. And when you do that, truly, we can talk about equality as our goal and sort of supporting individuals in a less tailored way, because the underlying fundamental problem, which doesn't sit in this image with the child and in our story with the families living with diabetes or the patients live or the individuals living with diabetes, but it really sits in how we've chosen to deliver diabetes care provision. Really revamping that, bolstering that, and straightening that is where our work sits now. And that's where I hope that the sort of evidence-based strategies that we've been discussing, as well as the reference to additional strategies, can really be a place of action, be a place of inspiration. And speaking of inspiration, these are many people that I get to work with, and I want to thank who I seek and get inspiration from all the time. So I want to thank everyone for their attention, and I really hope that this has been helpful. Please feel free to direct any questions that you have my way. Thank you.